Ladies and gentlemen, I'll invite you to come in here and participate in this session. I'm Val Johnson. I challenge anybody to say that they've come to this meeting longer than I have. I started coming when I was 17 years old in high school. And it's a little bit better attended now than then, but it has always been a great meeting. Our Thursday afternoon session now is sponsored by one of our long-term partners, the National Kidney Foundation of Utah and Idaho. I'm supposed to ask anyone to stand up if you are associated with the Kidney Foundation of Utah and Idaho, and then it says we will start to clap. Is someone going to stand up? Okay, thank you, that's enough. Our first speaker, we will have 3 sessions this afternoon, 3 speakers, and our first session is Dr. Matthew Grinsell. He's an associate professor of pediatrics at the University of Utah in the Division of Nephrology and Hypertension. Please welcome Dr. Matthew Grinsell.
Good afternoon. As mentioned, my name is Matt Grinsell. I'm one of the 6 pediatric nephrologists down at Primaries, and got invited to talk about diagnosis and management of pediatric hypertension, and I appreciate the offer. This is something that we do a lot, and I do enjoy. To start off with, this presentation has no ineligible content. I'm not getting paid by anybody. I'm not going to be supporting any economic ventures. I will briefly discuss a couple of apps that are helpful in blood pressure screening and categorization, and I will disclose that I have no problem telling my dog I love them way more than my kids in front of my kids, which I think is fun to do. So what we're going to try to do is review best practices for diagnosis and management of hypertension in the pediatric population, including epidemiology, etiology, and definition of hypertension, evaluation, and then management and referral. Globally, hypertension is a big problem. About 30% of people, or about 1.4 billion adults worldwide, have hypertension. It is the leading modifiable risk factor for cardiovascular disease worldwide. And of the top 15 causes of death worldwide, hypertension contributes or is causal for 5 of them. So definitely globally, hypertension is a problem. Here in the United States, 48% of adults have either blood pressure above 130/80 or are on blood pressure medications. But of those patients, only 25% have blood pressure in the goal range. And in the adult population, hypertension is the most common indication for both medical office visits and chronic medication use. Blood pressure in adults does increase with age. Between 20 and 40, it's about 1/4. Between 40 and 60, it's about half. And then above 60, about 3/4 of the individuals will have hypertension. So you have wisdom, you have high blood pressure. In pediatrics, it's a little bit different. Only 3.5% to 4% of the pediatric population have high blood pressure. Another 8% to 10% have blood pressures in the elevated range. We do know that childhood blood pressure predicts adult blood pressure, and in particular, adolescent hypertension very consistently tracks into adult hypertension. On the other hand, about 85% to 90% of the pediatric population do have blood pressure in the ideal range. So one of the challenges for my field and my folks is how do we identify that 35% to 40% of the population that's going to progress from normal tension into hypertension as adults. And that is an ongoing challenge for our field. So to start off with some cases, because I'm 80% clinical in my university position, so I spend most of my time in clinic. So 7-year-old presents for well child check. She's been a patient since birth, along with 4 of her siblings. During the check-in, MA obtains patient height and weight without shoes or coats, just like they're supposed to. Vital signs are obtained with patient seating. And then during the brief intake, mom mentions that the patient has had a couple or 3 days of headache, and she had a bloody nose last night that lasted about 45 minutes, and then this morning had an episode of dark brown urine when she got up. Once the MA rooms the patient and you're having those couple of minutes to kind of look over the documentation before you go in the room, the electronic medical record notifies you that her blood pressure is 136/92, which is stage 2 hypertension. Particularly for a 7-year-old, that's very high. The blood pressure was obtained appropriately by the MA trained in selecting the proper size blood pressure cuff for pediatric patients and using an automatic device. So, and when you're looking over your notes, you realize you just saw her about 3 weeks ago. At that time, she had a fever, and she had strep throat and was treated appropriately. And blood pressure at that time was completely normal at 92/60. The other thing that you notice is her weight is up about 1.2 kilos from 3 weeks ago. So what the American Academy of Pediatrics says, and what this clinic is doing right, is she came in for a well child check and she got a blood pressure. American Academy of Pediatrics says everybody should get their blood pressure checked annually. And then they recommend that everybody should get their blood pressure checked at each medical visit if they have certain conditions, and those are listed here. Obesity, kidney disease, diabetes, history of aortic coarctation, history of prematurity, or if they're on blood pressure elevating meds. And I'll talk more about that in a little bit. This is an example of the blood pressure cuffs we have in our pediatric clinic, and this is actually incomplete. I could not find the thigh cuff in this room, so this is everything but the thigh cuff. And there's a 2x2 gauze for size comparison. So this is a really important part of pediatric blood pressure management, is having that proper size cuff. Wait, did I? No, okay. So the other thing that we lost the screen.
Lost the middle screen.
The screen died. Okay, well, we'll just keep going on the other screen, I guess. Oh, the sound's in the other ballroom? Are you guys learning a lot about high blood pressure over there? It's very important to know about pediatric hypertension. Oh, well, I'm going to keep going. So the American Academy of Pediatrics there's about 30 key action statements in their recent guidelines for pediatric blood pressure. And one of them is for the use of oscillometric devices. So automatic devices are valid for blood pressure screening in children and adolescents. However, if there is elevated blood pressure based on the oscillometric readings, it is recommended that the confirmation be done with manual blood pressure with auscultation. One of the main reasons for that is our database that we use from NHANES for the pediatric blood pressures are all based on manual auscultation. So coming back to the case, so this is a 7-year-old girl. She had headache, nosebleeds, dark urine. Her height's 125 centimeters. Her weight is 25 kilograms, which is currently 75th percentile, but previously it was 60th percentile. Afebrile. Heart rate's barely a little bit high for a 7-year-old. Max heart rate's about 120, 125, and respiratory rate's fine. So we have this kid with headaches, nosebleeds, and dark urine. And it's almost like she knew how to read the chapter on how to present with a kidney issue. So what do we do with her now? Well, we need to figure out what stage 2 hypertension means in a 7-year-old, and we need to figure out what we're going to do about it. This is the definition of hypertension. So since 2017, when the American Academy of Pediatric came out with this last hypertension guidelines, that was the same year that the American Heart Association and American College of Cardiology came out with their guidelines. So the AAP has aligned the terminology and definitions for normal blood pressure, elevated blood pressure, stage 1 and stage 2 hypertension is the same as adults for 13 and over. They never really explained in the paper why they chose 13, but anyway, for patients 13 and over now, we use the same as the adult standards. For children younger than that, we use a statistical average where the blood pressure is based on the patient's gender, their height, and their age. Based on that, they can then end up with a bell curve of either normal blood pressure, 90th to 95th is elevated, stage 1 is greater than 95th to less than 95th plus 12. And if this does seem complicated, it is, which is why so many of us were happy that they simplified it for 13-year-olds at least. But it's still a little bit cumbersome for the 12 and under because, like I said, that data is derived from 50,000 patients in the National Health and Nutrition Examination Survey. But it's the best we got right now. This is just an example of part of one of the tables looks like. So here we have the patient's age. This is for girls, and then we have their height percentiles their height percentiles are here, and their blood pressure percentiles are here based on for systolic and diastolic. And you can see how this could be quite tedious to use on a daily basis, which is why they do have these apps. I would like to make it perfectly clear I am not getting any money from these apps. They're not paying me. But these are the two that I use, and they are quite helpful. The other option, which I think is pretty reasonable, is this is the table that for each age, it represents the 90th percentile at the 5th percentile height. So this is like the lowest blood pressure of the shortest person representing that age group is what they consider cutoffs for just screening. So if you need a quick reference that you just want to put on the wall of your office, this is a pretty rational approach. On the other hand, both of these apps are 99 cents. And this one in particular, you can plug in the gender, the age, the height, and the systolic and diastolic, and it'll give you not only the stage of hypertension they're at, but will also give you the management recommendations based on the 2017 guidelines. So I do find that one very helpful. Again, I'm not getting paid by them. It's called, that's a great question. I think it's PDBP. Yep, it's PDIBP is this one. But both these apps work well, but I do like this one because it gives you the management options. So coming back to our 7-year-old girl that had 2 to 3 days of headache, bloody nose, dark urine, blood pressure is 136/92. When plugged in, that is well above her stage 2 hypertension level. So what do? Well, you do what we always do. We go in the room and we start asking questions. Headache started a few days ago. She can't really locate it. She said it's definitely not in the front of her head. She thinks maybe it's like behind her ears a little bit. She cannot really describe the character too well, maybe throbbing. Tylenol and Advil haven't done a whole lot. She did notice that she had dark urine this morning, but she had no pain, hesitancy, frequency, or anything else that might suggest it was urinary tract infection. And she was otherwise alert, sitting in mom's lap, interactive. When you have a concern for blood pressure, the American Academy of Pediatric says you want to get a perinatal history, nutritional history, physical activity history, psychosocial history, and family history. And then physical exam on top of that. So fortunately for this family, you've known this kid since she was born. Her past medical history is pretty unremarkable. She was a term pregnancy. There were no pre or postnatal complications. She's up to date on her vaccines. She got PE tubes at 2 years of age. She's never had any hospital admissions. She does carry a diagnosis of ADHD, and she's on a fairly low-dose stimulant for that. There's no family history of hypertension, kidney disease, myocardial infarction, stroke, or death under 40 years of age. She is very active on the swim team, swims 2 hours every day. In fact, all the siblings are on the swim team. And the family generally eats mostly home-cooked meals without much added salt. They eat out once a week, but that's about it, and they generally do try to eat healthy even then. When you look at the review of systems for the hypertension, for a patient like this, they're all pretty nonspecific. And there's only 2 or 3 that are objective. And I would consider that bloody nose, vomiting, or edema, and perhaps diaphoresis. The rest of these are primarily subjective and can sometimes be a little bit tricky to tease out. But for her, she has headache and edema. So you do a manual recheck of the blood pressure in the right arm, and it's down to 128/90. That's still stage 2 for a 7-year-old, even though it's a little bit better. Otherwise, her lungs are clear. Her oropharynx and HENT exam, just a little bit of dried blood in her nose. Her eyes may be a little bit puffy, and her mom did mention that maybe she had a little bit of puffiness around her eyes in the morning. And then she has just a little bit of pitting edema on her shins about halfway up to her knee. So with manual blood pressure measurement, it's very important how you do it. What AAP wants you to do is have the patient sitting quietly for 3 to 5 minutes. If your clinic runs like mine does, it's like nobody is sitting quietly for 3 to 5 minutes between the waiting room and the exam room. What I do to account for that is I'll talk to the family, I'll get the interview and history out of the way, then I'll check the blood pressure. So I'll make sure the kid is sitting there realizing that I'm not a threat, and that when I go to do the blood pressure, it's going to be okay. You want the right arm supported with the cuff placed at the level of the heart. And then you want the proper size cuff is having the cuff bladder covering 80 to 100% of the arm circumference. And that's why multiple sizes of cuffs are necessary through the pediatric age range. You want the cuff placed at the midpoint of the arm, right there. And then typically inflate the cuff to about 20 to 30 points above the 95th percentile. And then the first opening snap is the systolic, and then the disappearance of sounds is the diastolic. There are certain populations, particularly very, very athletic adolescent males, that you can hear that blood pressure, that you can hear the heart rate go all the way down to 0. And at that point, there is kind of a muffling you have to hear, but it's not readily recognizable. It takes a while to kind of figure that one out. We do occasionally do leg blood pressures when we're assessing for coarctation. And with that, you want the patient in the prone position, have the cuff mid-thigh, and then the leg blood pressure averages about 10 to 20% higher than the arm blood pressure. So one of the another American Academy of Pediatrics key action statements is trained healthcare professionals in the office setting should make diagnosis of hypertension in a child or adolescent if you have manual blood pressures confirmed on 3 different visits. And again, these are guidelines, and I don't think this kid should wait 2 more visits. Like, her blood pressure is really high. I think it needs to be addressed now. So she has stage 2 hypertension, heart rate's a little bit elevated, but not excessively so. Now would be a good time, depending on your comfort level of managing high blood pressure. If you want to call us down at primaries, this is what we're here for. This is what we do. We work up high blood pressure all the time. In the meantime, while we're trying to figure out if you guys are going to call us, we need to figure out what the next step is. So that is going to mean arranging laboratory and imaging studies. So when we think about laboratory and imaging studies, we think about what are we looking for. In blood pressure, there's primary and secondary. And primary is essential, which I think is probably what most grown-ups see. But this has definitely been increasing in pediatrics with the obesity epidemic to the point where essential hypertension is now the predominant diagnosis for high blood pressure in teenagers. And we don't really know what causes it. Thought to be interaction of genetics and environment, which is what we say when we don't know what we're talking about. Secondary causes of hypertension. This is the cool stuff. This is what we see a lot in pediatrics. Especially in pediatrics, abnormalities of the kidney, either structural abnormalities, parenchymal injury, or renal vascular abnormalities, account for anywhere from 35 to 80% of secondary hypertension in pediatrics. There was more recently, they were recruiting for a blood pressure study on angiotensin receptor blockers in children under 6 years of age. And depending on the center, 63 to 74% of patients had renal origin of hypertension. So if you are thinking of high blood pressure in children, you should be thinking of kidney disease. And if you're thinking of kidney disease, you should be checking blood pressure because they really are pretty much inseparable. Other causes that are also, I know these are sick kids, but this stuff is interesting to work up. It's really amazing physiology here. But certainly endocrine disorders. Thyroid is interesting because both hypo and hyperthyroid can cause high blood pressure through different mechanisms. And then there are a number of genetic abnormalities of mineralocorticoid, either expression or receptor abnormalities, and congenital adrenal hyperplasia can contribute to hypertension. Neuroendocrine tumors like pheochromocytoma, paraganglioma, aortic coarctation or congenital heart disease, single gene disorders, which are very interesting physiology. Little and Gordon syndrome. So Little syndrome is an abnormality of the epithelial sodium channel, and I think Gordon syndrome is an abnormality of the Wnt kinase and the collecting tubule. And then ARPKD, ADPKD, Alport are all single gene disorders that can be associated with hypertension. Ingestions and environmental exposures, and then miscellaneous disorders such as Williams syndrome, cyclic vomiting, or other systemic vasculitides that our rheumatology folks help us with. There's a lot of pharmacologic agents, both over-the-counter, recreational, and prescription that can cause high blood pressure. This is far from a complete list, but it probably hits a lot of the highlights. Decongestants cause it. We get caffeine, non-steroidals. A lot of herbal supplements will do it. Ma Wang, ephedra, licorice fruit, and guarana can all cause high blood pressure. The National Center for Complementary and Integrative Health has a great database, so you can just pop in any herbal somebody's taken, and they'll give you the best data on whether or not they know if that causes high blood pressure. I find it's a very useful website. Certainly stimulant medications can, oral contraceptive pills, steroids, and calcineurin inhibitors, which are commonly used in transplant population. So back to our little girl. So she has high blood pressure. We need to evaluate for secondary causes. So the American Academy of Pediatrics could not come up with a key action statement on laboratory evaluation for hypertension. And I can guarantee you it's because there were some massive nerd fights going on about what labs. So there really isn't there's a secondary recommendation, but it's a little softer. So for this patient, I ordered a UA with micro, kidney function panel, CBC, and then C3 and C4, which are complement proteins. Here's what the AAP recommends for stage 2 hypertension. They say all patients should get these. And this little girl, who's only 7 years old and previously completely healthy, I held off on the lipid profile because I didn't think that was going to change a whole lot of what I do. And then if there's obesity or other medical complications, that increases the laboratory evaluation. Another thing the American Academy of Pediatrics says is Doppler renal ultrasonography may be used as a non-invasive screening study to evaluate for renal artery stenosis in normal weight children and adolescents over 8 who are suspected of having renal vascular hypertension. I think my partners and I are a little more liberal than that. I think anybody with high blood pressure pretty much gets a renal ultrasound from us just because it's cheap, non-invasive, and it does give you a lot of useful information. Another key action statement is in hypertensive children and adolescents who have failed lifestyle changes, particularly those who have LV hypertrophy on echocardiography, symptomatic hypertension, or stage 2 hypertension without a clearly modifiable factor. And then they say clinicians should initiate pharmacologic treatment with an ACE inhibitor, angiotensin receptor blocker, long-term acting calcium channel, or thiazide. I do not agree with this action statement only because I would not have patients with left ventricular hypertrophy, symptomatic hypertension, or stage 2. I would not have them try a 3-month trial of low salt. That's not going. You're going to have end organ damage. So I don't know how this one particularly got through, but I think because lifestyle modifications are supposed to be for 3 to 6 months. This is not a patient I would wait for 3 months. But if they're under stage 2, I think lifestyle changes are an excellent first choice. Quick note on the type of medications. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers, they effectively kind of alter how blood flows inside the kidney. And so there's a genuine risk that you could cause kidney damage if you use an ACE or an ARB in the context of renal artery stenosis. So if you even think there might be renal artery stenosis and you don't know what you're treating, it's like I would start with a calcium channel blocker or a beta blocker, not an ACE or an ARB. Those are not good empiric agents in this population. And just because, everybody has their N of 1, but I did see a kid have a chemical nephrectomy because he was given an ACE inhibitor with undiagnosed renal artery stenosis. Fortunately, it was only unilateral, but it's still, an avoidable complication. So coming back to her, we got our labs ordered, we got our ultrasound ordered. Again, not a bad time to reach out to me or somebody in my group because this is what we're here. This is what we're here for. So as far as management, this is most likely an acute post-infectious nephritis, especially with their strep 3 weeks ago. Hypertension is due to increased activity of the renin-angiotensin-aldosterone system. And even though it is the renin-angiotensin-aldosterone system driving the high blood pressure in this situation, there is a significant risk of acute kidney injury. So generally we avoid treatment with those medications, and we generally use calcium channel blockers. And by and large, those work just fine. These kids are on them for maybe 2 to 3 weeks, and then they come off anyway. Diuretics may also be an option depending on the level of fluid overload. So American Academy of Pediatrics says, treatment goal at this point, either non-pharmacologic or pharmacologic, is to get the blood pressure less than 90th percentile if they're less than 12 or less than 130/80. Now for our patient, remember she's at 136/92. We want her down to 109/70. Let's see, here we go. So started her on amlodipine at 2.5 daily, which is a starting dose of 0.1 milligram per kilogram. Really encourage the family to watch the salt intake. For a 7-year-old, probably keep it between 12 and 1,500 milligrams a day. Her creatinine came back a little generous at 0.8, and when you calculate her GFR, it comes out to about 65% of normal, which is, it's like you wouldn't think a creatinine of 0.8 in a 7-year-old would be that big of a decline in kidney function, but these kids can have a pretty significantly reduced function. The rest of her metabolic panel looked good. She didn't have an elevated BUN or acidosis. C3 was low at 20, and her C4 was normal, which is very consistent with post-infectious nephritis. And her ultrasound just showed some non-specific increase in echogenicity with otherwise preserved corticomedullary differentiation. And that just means the kidney's not happy for some reason. So we started her on blood pressure medicines, had her follow up for a blood pressure check in 2 to 3 days, and it had normalized. And then she was able to come off blood pressure medicines 3 weeks later, and then her labs all normalized by 8 weeks, which is very consistent with post-infectious nephritis. And like I said, 3 days after, clinic visit was 111/68, and then 104/64 again 3 days after that. So she was able to come off the medications, and her C3 recovered. At the follow-up visit, her mom did wonder, it's like she was on the ADHD stimulants, could those have contributed to her high blood pressure? And that is a good question. And what we know about stimulants is that there is a growing body of evidence that they can raise your heart rate pretty good, up to 12 beats per minute. They increase your systolic by 3 to 4 and diastolic by 2 to 4, almost regardless of age. They just kind of bump everybody up a little bit. And these do go away with discontinuation of the medication. So those increases in the systolic and diastolic are statistically significant. I'm a little skeptical if they're clinically significant because, I mean, I measure blood pressure for a living, and I can measure blood pressure 4 times on the same kid and have this much variability. So I'm just not sure if 3 to 4 makes a difference. But you know, I do have the advantage that I don't prescribe the stimulant medications. So for the people that do, you have to balance that potential cardiovascular risk, which at this point is very potential. We do not have an established cardiovascular risk from these medications, versus the beneficial effects. And for some kids, these do really help make a difference scholastically. So going on to another case, going a little bit younger, got a 5-month-old, former 23-week or 27-week premature infant. He spent about 12 weeks in the NICU, and then his stay was complicated by bronchopulmonary dysplasia, requiring prolonged intubation, and he did get surfactant in the delivery room. At about 6 weeks of age, hypertension was noticed, and then about 3 weeks after that, he had a urinary tract infection with E. coli. He did not have any umbilical artery catheters placed. He had an umbilical venous catheter, but not an artery catheter. At the time, he was 6 weeks of age, at which time he was 33 weeks corrected gestational age. An echocardiogram was obtained because of the hypertension, which just showed a little bit of mitral or tricuspid regurgitation without anything significant. With the urinary tract infection he had at 9 weeks of age with E. coli, they did get urology involved, and they got some imaging which showed right hydronephrosis, and then a subsequent VCUG which did show high-grade bilateral reflux. And this is this patient's imaging studies. So this is his right kidney, and right here, this, and this is the little bit of hydro. But then here's the voiding cystourethrogram, and you can see that going all the way up into this. This does not do justice to how dilated this right collecting system is, and here it is over on the right side. This guy has big-time bilateral reflux, which is, in addition to prematurity, that's a separate risk factor for high blood pressure for this child. So he comes into clinic. He was discharged on 1 milligram amlodipine twice daily. And that was started after my team was consulted in the NICU. Blood pressure in clinic is 102/60 with a proper sized infant cuff. So what do we do with this kid? Like, is 102/60 an okay blood pressure for a 12-week-old or a 5-month-old former 27-week infant? So he's now corrected gestational age to about 47 weeks. But we do know that just based alone on the presence of reflux, he now meets diagnostic criteria for being called chronic kidney disease. So as far as figuring out if his blood pressures are acceptable, the American Academy of Pediatrics recommends this graph up to the post-conceptual age of 46 weeks. Our patient right now is at 48 weeks. So this graph does not apply to him. When after 46 weeks, they then get broken down, and these are the recommended graphs to use that have girls birth to 12 months for systolic and diastolic, and boys for systolic and diastolic. So our guy here, he was born at 27 weeks, and he's now 5 months old, so he's about 47 weeks estimated gestational age, and that would put him right about here. So his 90th percentile blood pressure is going to be about 105 over maybe 60, high 50s, and he was 102/62, so he's barely above goal. Plan to monitor this guy every 3 to 6 months for the first year, and then we space out the visits. I generally keep these kids on the amlodipine because I like that it's gentle, it doesn't really cause side effects in these kids, and unlike an ACE or an ARB, if you get dehydrated, it won't cause acute kidney injury. Calcium channel blockers are the way to go. Full disclosure, for 2 years before I went to medical school, I did nothing but basic research on calcium channel blocker physiology, so I do have a ridiculous bias, and I'm very open about that. I think they're great. This is definitely a guy, too, that will need to be monitored for recurrent urinary tract infection, because even though he had the massive bilateral reflux identified, because of his comorbidities and his size, urology has not done any kind of ureteral surgery, so he's just on a little whiff of an antibiotic to prevent UTIs for the time being. Between the high blood pressure and the reflux affecting the kidneys, this guy is going to be a long-term nephrology patient. So going on to another quick case. So this is a 15-year-old male referred for elevated blood pressures over the last 4 to 5 years. Unfortunately, he's currently in the care of his grandparents. Neither one of his parents are capable of caring for him at the time. Outside blood records show that his blood pressure is running kind of 128 to 138 over mid-70s, kind of sneaking up over the last couple years. So he's kind of gone from elevated blood pressures with systolics in the 120s to now stage 1 hypertension with systolics pretty firmly in the 130s. So fortunately, I have 2 amazing nurses that keep an eye out on these referrals that they come through. So a lot of them were able to get studies ordered before they see us in clinic. So we were able to get this guy labs, imaging, and an ambulatory blood pressure monitor ahead of the visit. As the American Academy of Pediatrics says, getting a thorough history. So he's currently on treatment for anxiety, followed by a child psychiatrist. Never had any surgeries or hospitalizations. Lives with his maternal grandparents. Not very active kid, just kind of comes home and watches TV after school. Family history is pretty positive. His paternal grandfather had a myocardial infarction at 35 years of age. He's now 45 and on dialysis. His biologic father and a paternal uncle both have diabetes. Both maternal grandparents have diabetes and hypertension, and there's numerous family members with obesity. Once again, looking at a review system on a guy like him, he did have a little bit of snoring and some fatigue and anxiety, but that's about it. And that's not that uncommon with this relatively low grade of high blood pressure. On physical exam, blood pressure was 138/74 in the right arm. 4-point blood pressures had similar blood pressure in the left arm and then a little bit higher in the legs. So pretty much can rule out anything like a coarctation causing this. BMI was 34, which meets the diagnostic criteria for obesity. And he did have some acanthosis around his neck and a little bit of his antecubital fossa. The ultrasound with Doppler before clinic, completely normal. Kidney and urinalysis and kidney function and CBC were all normal. And somebody had done a thyroid studies and A1C a couple months previously, and those were unremarkable as well. So one of the newer updates from the American Academy of Pediatrics is if you're over 6, you do not need a huge evaluation if you have a positive family history for hypertension, or overweight or obese, or do not have any physical exam findings suggestive of secondary hypertension. So basically no CTA or MRA or renin-aldo, metanephrines, or catecholamines. Ambulatory blood pressure monitor is a technology we've been using for about 15 years, and it's pretty much becoming the gold standard in my world. And this is just an oscillometric device that hooks up to a blood pressure cuff that you can wear on your belt, takes blood pressures every 30 minutes for 24 hours, including while sleeping. We provide this as a service through our clinic. We have about 20 of these machines right now. It's really nice because it does allow measurement of blood pressure outside the medical setting. So it's pretty much become the gold standard for evaluation of white coat hypertension. And it also allows for measurement of nocturnal dipping, which is a cardiovascular risk factor noted in obese people. The one drawback is these are about $5 a pop. And you get about $40 for reading one of the monitor tests. So these are not money makers. So this is this guy's ambulatory blood pressure test, and what it shows us is his daytime average blood pressure was 133/61, and his nighttime blood pressure was 113/51. So this is actually very consistent with kind of like obesity caused stage 1 hypertension, is it tends to be mostly systolic and not diastolic. And this kid has normal diastolic, but elevated systolic pressures. And he does have reasonably good preserved dipping so far at nighttime. So he meets the criteria for stage 1 hypertension. For this guy, what the AP says is you want to confirm blood pressure in children with blood pressure and hypertension in children with measurements in the elevated blood pressure category for 1 year. So if they're elevated blood pressure, they have to be there for a year. If it's stage 1, it's just over 3 separate visits. If there's high-risk conditions, again, obesity, diabetes, heart disease, transplant, that hypertension severity maybe need done so that you can assess for target organ damage. I know what I'm saying, I swear, target organ damage. If you have a kid who has suspected white coat hypertension, which is hypertension in the medical setting and normal tension outside the medical setting, we can do that based on the normal blood pressures on the ambulatory blood pressure monitor. And the ambulatory blood pressure monitor is also a good way to monitor treatment effectiveness in children and adolescents with hypertension. And it's actually, we've gotten to the point where every one of our transplant patients gets an ambulatory blood pressure monitor at least once a year, and every one of our dialysis patients gets an ambulatory blood pressure monitor test at least once a year. That's what we've instituted because we find these very useful technology. Home blood pressure monitoring should not be used to diagnose hypertension. but it can be used to help monitor treatment. I would say about half my family's home blood pressure monitoring seems to cause more anxiety than anything. They get very, very focused on it, and I don't find it as helpful. The other thing we did for this guy, counseled the DASH diet, encourage more physical activity, try to reduce screen time, and then come back in 6 months. And what the American Academy of Pediatrics says is just that. When you diagnose somebody with blood pressure, counsel them on the DASH diet and encourage physical activity. And the DASH diet was developed by the National Kidney Foundation back in the 90s for the dietary approaches to stop hypertension. It focuses heavily on salt restriction, increasing intake of fruits and vegetables and less processed foods, and then less meats and saturated fats. So this guy, we told him to do that, had him come back in 6 months. His weight was up 3 kilograms. Blood pressure in clinic was 136/76. So the indication was to initiate pharmacologic therapy. So this kid was a good candidate to start an angiotensin receptor blocker. We did that, came back at 3 months. His blood pressure was in the normal range. And we did get an echocardiogram ordered at the time of the losartan initiation. Unfortunately, he did not have any LVH at that time. So as far as echocardiography goes, echocardiography can be performed to assess target organ damage at the time of consideration of pharmacologic treatment of hypertension. So if you're thinking about doing meds, it's okay to get an echo. I do order echoes on patients that actually start medications on. So this guy had obesity. Obesity and hypertension are linked, and it's across all age groups. These definitely track into adulthood. Rates of hypertension in pediatrics increase in a graded fashion with adiposity. And we know that from the Bogalusa heart study that overweight children were 4.5 times and almost 2.5 times as likely to have elevated blood pressures compared to their non-obese counterparts. And it's thought to be really due to sympathetic overactivity, insulin resistance, vascular structure, increased salt sensitivity, or probably a combination of all of them. This is what happens to blood pressure and BMI in kids. So even at like 50 to 75th percentile BMI, you start seeing a little bit of a click up in high blood pressure, but then when you start getting in the higher BMIs, blood pressure percentage rises precipitously. Here's a little graph looking from 1963 to 2018. This is the percentage of hypertension in 2 to 5-year-olds, and then 6 to 11-year-olds is the green, and 12 to 19-year-olds. And so 1971 is when we approved high fructose corn syrup. 1976 is when high fructose corn syrup entered the food chain, and then Nintendo, PlayStation, and Xbox. So I don't know if they're causative, but I like putting this graph out there just because I think it helps me tell people to not have more screen time. Final case. So the previous cases were an amalgamation of patients I had. This is a single patient, and this is why I went into this job. This is very interesting. So an 11-year-old got hit in the chest playing a football game. Blood pressure 110/70 in the ER, or 170/110 in the ER. And it stayed 170/110 for his entire ER visit. He was otherwise completely asymptomatic. The ER was able to get him into a cardiologist, pediatric cardiologist, within about 48 hours, or 3 days later. And he got an echo and started amlodipine, and the echo showed an LVH with a z-score of 3. That means it's more than 3 standard deviations thicker than it ought to be. This is significant LVH. But otherwise, the kid had a completely normal metabolic panel. His UA had no blood or protein. And so he was sent to us to figure out what was going on. By the time he came to us, he'd only had 2 doses of amlodipine, but even then, that did help. get his blood pressure down to 150 over 96. And the reason that matters is it usually takes about 5 to 7 days for amlodipine to reach full effect. It has a ridiculously long half-life. So once again, my great nurses were able to kind of flag this one down, so we were able to kind of get him worked up before he came into our clinic. When I saw him, the only review of systems he had is like, yeah, I've been having some like weekly nosebleeds throughout the last month. Otherwise, term birth, family history negative, the kid really physically in great shape. The family eats very healthy. His only surgical procedure his whole life was the circumcision. And he lives with parents and 2 older siblings, and everybody was pretty functional. On exam, he was not obese. BMI was 17.3, which is 45th percent. Blood pressure 158 over 108 in the right arm. And left arm was 154 over 112. Right leg was 170 over 120. The rest of his physical exam, he had a bruit just above his umbilicus. So fortunately, he'd had an ultrasound before clinic, so right when I was finishing the physical exam, the ultrasound read popped up, and sure enough, abnormal appearance of both the mid-aorta as well as proximal portions of the renal arteries. He had elevated velocities, dampened waveforms, so he had a lot of imaging evidence of renal artery stenosis. So the American Academy of Pediatrics says if you're concerned about renal artery stenosis, you're going to want to get a CTA or an MRA. Those are the only 2 imaging studies that will work for renal artery stenosis. So, I prefer CTA because they're quicker, cheaper, and they give you a little better anatomy. So we ordered that, and this is him. This is his actual right renal artery. So you can just barely see that. This is his left renal artery. There's a stenosis there and another one there, and that is his aorta. His aorta is like a little piece of spaghetti. This guy has something called mid-aortic syndrome, probably due to Takayasu's arteritis. Oddly enough, despite having wicked renal artery stenosis, his aldosterone was normal, his plasma-renin activity was normal, he didn't have hypokalemia or alkalosis. I was expecting all this great stuff. All of his, even his immune markers were negative, which my rheumatologist said wasn't that surprising. So we ended up, it took us a few months to get this guy, his blood pressure under better control. But then when we finally did, he got hooked up to the mid-aortic clinic at Boston and went there, and they did a surgery and seemed to have improved him a little bit. So a few months later, he wanted to start going back to sports and weightlifting, because with those blood pressures, I said, absolutely no, you're not doing sports with a blood pressure of 150 over 100. But, you know, I don't do this job so people can not get out and do things. I want people to be as physically active as possible. And at that time, his blood pressure was in the, just in the elevated range. So the American Academy of Pediatrics says, okay to participate in competitive sports once your target organ effects and cardiovascular risk have been assessed. And then children and adolescents with hypertension should receive treatments to get at least below stage 2 before participating. And I do consider weightlifting as part of competing in sports because Olympic weightlifters, their blood pressures get up to about 400 over 200. So weightlifters can have, for a very short time, but ridiculously high blood pressures, which kind of explains all the burst blood vessels and things that they suffer. So here's the AAP guideline for checking blood pressures. You know, you have have them seated and then using either an automated device or manual blood pressure. If the blood pressure is less than the 90th percentile, you have normal blood pressure. If it's higher, remeasure the blood pressure twice in that visit, and then you average it. If the average of those 3 measurements is below the 90th percentile, you have normal blood pressure. If the average of those measurements was above the 90th and they were all done with auscultatory, then it's time to start doing more of a workup. Blood pressure should be checked yearly and at each visit with certain risks. If you have a patient with high blood pressure, you should be checking for kidney disease and vice versa. If your blood pressure is normal, just check it yearly. If blood pressure is elevated, recheck in 6 months. If it's still elevated in 6 months, check in upper and lower extremity blood pressures, talk about lifestyle modifications, and come back in 6 months again. If it's still elevated in another 6 months, then refer for more formal evaluation. For stage 1, with the first blood pressure reading, you counsel lifestyle changes and repeat blood pressure in 2 weeks. If it's still high in 2 weeks, say, watch your salt, you check your upper and lower extremity blood pressures, and then come back in 3 months. If it's still high after that 3 months, then again, proceed with more evaluation. And then if it's stage 2, which is like we had with our first patient with the post-infectious nephritis, and I don't really, for stage 2, it's not so much counseling lifestyle changes. I say just, you got to stop eating as much salt. Check your upper and lower blood pressures, looking for coarc. You want to refer to specialty within 7 days or sooner if they're having symptoms. The most common ones are going to be blurry vision, bloody noses, or headaches. Or you can just call our team. And then if it is stage 2, you also want to initiate evaluation and treatment, often in concert. So if at any point during the evaluation of hypertension, if you want help or want some guidance, this is how you get a hold of our team. There's the PCH Physician Access Line. This is our nephrology office, and this is our fax number. And one of us is available 24/7. So that's all I have. I went over by 3 minutes. I appreciate you letting me come here and talk about this. I find this really interesting, and I like to share it, so thank you.